I'd like to thank the organizing committee for having us here, and also for a lot of congratulations for arranging such a wonderful event. How many residents do we have in-house? Guys, first presentation in the morning, how many residents do we have in-house? Raise your hands. Okay, so sizable number of residents. So today's presentation will primarily be targeting the younger audience here. We'll try and run through basic staging, basic guidelines of rectal tumors. Nothing very elaborate. We'll take you from the basics and try and sort of unravel or simplify how you can go ahead and interpreting patients who have rectal cancer. Okay, so we'll be talking about imaging in rectal cancer, guidelines and staging. I'm sorry there is no mouse, Agar Raima. If we can have a mouse, because I'll have to show things. We'll start in the meantime. So we'll be talking about imaging in rectal cancer, guidelines and staging. I have no disclosures. So the learning objectives of today's presentation would be, we'll talk about the introduction, we'll talk about the imaging modalities of rectal tumor, we'll talk about the relevant anatomy. Mike, agar mil jaye, please. Mike. We'll talk about the relevant anatomy and then we'll move on to the staging of rectal cancers. So rectal cancer is defined as cancer that involves it's usually on histopathology, an adenocarcinoma that involves the distal 15 centimeters of the intestinal tract, and it is measured or from the anal verge, whichever preference an institution has. It is one of the major causes of mortality related to cancer worldwide. Although imaging can be suggestive of cancer, especially in patients who come in with intestinal obstruction or who have already had problems before, usually MR staging or radiological staging is used for patients who have already been diagnosed as having rectal cancer, and they come to you primarily to assist in triaging what the appropriate line of management would be for patients who have rectal CA. The objective is to have negative surgical margins, all right? So the only mainstay of treatment is if you can go ahead and operate the patient and have negative surgical margins, because that is the gold standard of treatment. So it means that there should be no tumor on the resected surgical specimen within 1 millimeter of the resected margin on histopathology. And that is the only gold standard for locally curative treatment. Failure to attain negative margins would lead to poor outcomes, would lead to recurrence and overall poor quality of life and poor disease-free survival. So the objective again is primarily to have surgery performed for the patient. I cannot emphasize enough on how much this is a multidisciplinary approach. A lot of hospitals will try to keep radiologists in isolation. Dr. Najib is sitting here. I can tell you, it cannot work without the coordination of the oncologist, of the radiation oncologist, of the pathologist and the radiologist and the surgeon. All 5 of them together will sit together, have a multidisciplinary meeting, decide what is the best way forward for the patient, and then treat accordingly. So it has to be a multidisciplinary approach. So why an MR? So like I said initially, a lot of these patients will already have a diagnosis of rectal cancer, and when the request comes to you for rectal cancer for an MR, they want to know the stage because they want to determine the appropriate next line of management. So MR is used because you can adequately identify the stage of the disease. You can look at the depth of invasion, which is beyond the muscularis propria, and we'll be discussing the anatomical landmarks later. The relationship of the mesorectal fascia, the anal sphincter, and the pelvic side wall. These are important anatomical landmarks which will allow you to stage properly. And then there are other terms like circumferential resection margin, extramural venous invasion. We'll be talking about all of these. The sphincter complex status and the extramesorectal lymph nodes. Now, rectal cancer is a very broad topic. We'll be concentrating more along the upper and mid sections of the tumors. Lower rectal cancer or extending into the anal margins, they have different kinds of staging. So what is the best protocol for imaging patients who have rectal CA? This is according to institutional protocols. Different institutions have different protocols, but normally the basic concept is to have a small field of view, images required in all axial, coronal and sagittal sections. So you'll see, we don't have a pointer here, but if you look at the top left image, you can see you have a nice sagittal image. It is very, very important to obtain what is called oblique axial images. So what are oblique axial images? We try and obtain images along the perpendicular line starting from the center line of the rectum. So if you can look at the image along the bottom left, you can see a hypointense rim around the rectum, but along, yeah, thank you. So you can see this area along the right anterolateral wall where there is puckering, and one would think that tumor is extending beyond the muscularis layer and going forward. So it is very important to have oblique axial images, because then you go ahead and see on oblique images that the hypointense rim is preserved. So it is important to have oblique axial images to appropriately stage. The next important bit is to also have proper oblique coronal images to look at tumors when they are extending through the anal canal. So if you look at the top image over here, an oblique coronal image will allow you to stage the disease properly, look at it anatomically, how it's related to the sphincters. Beyond this, it is important to have images acquired in a wide field of view all the way up to the aortic bifurcation to look at para-aortic lymphadenopathy and any additional lymph nodes that are around. Images are required in T1 pre and post contrast. Diffusion weighted images are very, very important that are required initially, and they play a role along with post gadolinium images in MR restaging when the patient comes back after neoadjuvant therapy. There is a role of giving anti-motility agents like Buscopan, anti-spasmodic agents, so that you can reduce the motility of the gut. And so images are static. There is very little motion artifact when you are acquiring MR images. So this is again the same axial view, but just to give you an anatomical outline, again, if you acquire an oblique axial view, you see the inner hypointense line. This is the submucosa, and the hyperintense rim, that is the mucosa. We'll be talking a lot about this last hypointense rim, the outer lining of the rectum, which is the muscularis propria. It has a very important role to play whenever we are staging, especially in the T-scores for rectal tumor. So we'll be talking a lot about the muscularis propria. Other anatomical terms that we will be talking about will be the mesorectal fascia. So you can see this very thin black hypointense line. So you have the mesorectal fat, that's the rectum. This thin hypointense line extends beyond the mesorectal fat, and that's the mesorectal fascia. And that is an independent prognostic marker, and again, either can upstage the disease or downstage the disease, and we'll be talking about the importance of this when we talk about staging. Another anatomical landmark is the anterior peritoneal reflection. Now, you would assume that once you have the covering of the mesorectal fascia, that is what extends all the way along the upper and mid section of the rectum, but it's not the case. You have the anterior peritoneal reflection, which is a covering of the peritoneum, a peritoneal lining that extends along the proximal half or proximal 1/3 of the rectum. It is very important to identify, because this little bit can suddenly upstage the disease. If there is involvement of the anterior peritoneal reflection, then the disease is upstaged. So it is very important to identify this on sagittal and also on axial images. So if you've got a good quality scanner, you can see this T-shaped structure. This is part of the anterior peritoneal reflection. So if the tumor does not involve this peritoneal reflection, it is a lower stage tumor. This is just an anatomical representation, if I can explain to you. So if you divide the rectum into high rectum, mid rectum, and lower rectum. So if you divide it into 3 portions, the upper part of the rectum is completely enveloped with the peritoneal lining from the peritoneal cavity. The mid portion has the peritoneal reflection only along the anterior third. So the lateral bit and the posterior bit do not have the peritoneal reflection. And as you go lower down into the rectum, the entire thing is covered by the mesorectal fascia. So it is important to delineate these two anatomical structures separately. Now, every hospital, every institution has their own policy regarding reporting of MRs for patients who have rectal cancer. We normally try and use this algorithm. It is the Society of Abdominal Radiologists algorithm for reporting rectal CA. They had an update that came out in 2022. You can't read this very well over here, but it tells you about the distance of this. So there are multiple markers that you have to put up in the report. It helps the oncologist, it helps the radiation specialist, it helps the surgeon to localize and decide in the multidisciplinary approach how to go about treating this patient. So it includes distance from the anal verge, distance from the anal sphincter, relationship of the anterior peritoneal reflection, the craniocaudal length of the tumor. We'll talk about the morphology and the mucinous composition. And then you go on to stage the disease according to the T-scores. Don't be confused by this, this form. We'll take this one by one. So the first step is identifying the tumor. A lot of times you're just able to see the tumor right exactly where it is, but I can't emphasize enough on trying to utilize clinical notes that have been provided to you. Like I said initially, a lot of these patients are going to come up after they have already been given a diagnosis of rectal CA, and then they're going to come to you for an MR for staging. So if you already know where the tumor is based on the colonoscopy report, based on the surgeon's assessment, you can utilize that to add onto your imaging findings. So over here you can very clearly see that there is a lesion. So the first step is finding the tumor, look at the tumor signal. Normally they have an elevated border, especially, for example, in this image you will have elevated border, so you can utilize this to your advantage. The second bit is identifying the location of the tumor. So like we said, rectal tumors can be described as upper rectum, mid rectum and lower rectum. It is important to delineate the distance from the anal verge. Now this is very similar to what the surgeon would experience or the gastroenterologist would experience from the anal verge. One of the best ways to measure this is to take a very nice sagittal image and have different measurements that go all across the center of the anal canal all the way up to the caudal aspect of the lesion. And this is a fairly standardized agreement. You have to decide whether there should be an institutional agreement whether you measure from the internal sphincter or the external sphincter. But if you measure from the anal verge, usually the measurements are very similar. So it's important to measure it on a mid-sagittal plane that goes through the mid portion of the anal canal. Again, in the location, it is important to identify the location and its relationship to the peritoneal reflection. So this is very important to measure separately. We've discussed this previously as an anatomical landmark, but to explain this in the report is very important because this will decide the stage of the disease. Then we move on again, beyond the location and relationship to the peritoneal reflection, you measure the disease craniocaudally, measure what the distance is like. This also has to go up as part of the report. As we move beyond the size and location, the next step is this T stage, which is very important as far as staging of the disease is concerned. So if you look at the image on the right, there are 4 circles, red circles, however much you guys can see, but everything is about the muscularis propria layer, the initial hypointense layer that we talked about. If the tumor is confined within the hypointense layer, then the disease is T1 to T2. On MR, you are not able to differentiate T1 and T2 disease. If for some reason it is imperative, then you go ahead and get an endoscopic ultrasound done. But for MR staging, we will categorize this as T1/T2 disease as long as the muscularis layer is preserved. The moment we go beyond the muscularis layer, then the disease is automatically T3. Now, you have to mention how much it has extended beyond the muscularis layer, and that would tell you whether the disease is T3A, B, C, or D, based on the distance of how much it has infiltrated from beyond the muscularis layer into the mesorectal fascia. So you can see, again, if it is less than 1 millimeter, it is T3A. If it is between 1 to 5 millimeters and onwards, so T3A, B, C, and D, that is how you'd categorize it. Then we talked about the anterior peritoneal reflection. And this is where it matters in stage. So if the tumor involves the anterior peritoneal reflection, irrespective of the tumor size, the tumor automatically becomes T4A because it is considered as having invaded the peritoneum. So T4A is reserved for tumor that extends all the way up to the anterior peritoneal reflection. And for upper rectal tumors, it is not very difficult for tumor to extend up to this level. So as long as it involves the mesorectal fascia, it is still low grade. The moment it moves on to involving the anterior peritoneal reflection, then the disease is upstaged. We move on to 4B, which is essentially all other adjacent structures. The tumor that extends beyond the mesorectal fascia, it involves the pelvic organs, skeletal muscles, vessels or nerves, bones, or any distant bowel loop. The tumor becomes T4B. So I've tried to simplify as much as I can for T scoring. So remember the muscularis propria layer. As long as the hypointensity is maintained, tumor is within T1, T2. The moment it goes beyond the muscularis layer, it is either T3, T4. Now you decide what it has involved anatomically to decide whether it is T3 or T4. Then comes an independent marker. We talked about the mesorectal fascia. So just like the anterior peritoneal reflection, we talked about the mesorectal fascia, which is this hypointense layer that surrounds the mesorectal fat. So the moment, this is very, very important to mention in the report whether the tumor has extended into the mesorectal fascia or not, because like we said, surgical planning is key, and they have to try and decide if the patient can undergo total mesorectal excision or not. So that is the gold standard of treatment. If a patient has total mesorectal excision, that that involves excision of the rectum with the mesorectal fat, with the mesorectal fascia. Everything has to come out. So if tumor is extended up to this level, you consider this as locally advanced disease. Beyond that, then you start looking at whether there are lymph nodes involved, whether there are any non-contiguous segments of the tumor, or whether there is extramural vascular invasion. So we talked about EMVI initially also, but what is EMVI? So all structures in the body are eventually supplied by blood. So you have these linear tubular structures that are basically blood vessels which supply the rectum and also correspondingly supply the tumor. There can be instances where the tumor infiltrates these blood supplies and tries to extend cranially. So this in itself is an independent negative prognostic marker. And if the patient has this, the disease is upstaged. So for example, the image on the right, you can see the disease is not extending up to the mesorectal fascia, but there is this long tubular structure that goes along to the arrow, and this is where the tumor is actually extending into one of the blood vessels, and this is extramural vascular invasion. This is something that the oncologist and the surgeon both really want to know because it plays a role as far as staging is concerned. So T done. Now we move on to the end stage. So normally we know how important size plays a role as far as nodal assessment is concerned. In rectal cancer, size does play a role, but a lot also depends on the morphology of the lymph nodes. So if you look at the appearance of the lymph nodes, there are 3 specific criteria that need to be described about the lymph node, whether the shape is round or not, whether it has any signal heterogeneity, and whether it has irregular borders. These 3 have been separately assessed to find out that if they are present, then they individually have a higher risk of tumor extending into the lymph node, irrespective of the size. So here is a table that tells you even for people who have lymph nodes less than 5 millimeters in size, if all 3 are present, which means they are round, they have a heterogeneous signal, and they have irregular borders, you will consider that as node involved by the having tumor deposit within it, and the patient becomes node positive. Then moving on, if a person has a lymph node that is 9 millimeter or greater, even if none of these features are present, based on the size alone, the patient will have node positive status. So these 2 are important. So size and morphology both need to be considered when we evaluate the end stage. And then from here on, basically just look at everything else. I mean, if you see any additional lymph nodes, you see any additional, any contiguous deposit within the bowel loops, you see any peritoneal disease on diffusion or on post-contrast images, so you need to report all of those things. As you move from the T and N stage, then you have the metastasis evaluation. Now, it's not necessary that that will be done on an MRI of the pelvis. A patient may already have had a PET scan or had a CT, contrast CT chest abdomen pelvis. That will help you in assessing whether the patient has metastasis or not. The moment you want to stage the disease, if assessment has not been done, you label it as MX. If the assessment has been done and there is no distant metastasis, the patient is M0. And if there is distant metastasis, the patient moves on to M1, which is subsequently categorized as M1, A, B, C, depending on where it's spread. Stage groupings are again a way of trying to compile the T and an M. We normally don't see patients in stage 0, which is tumor in situ. You will find patients between stage 1 and stage 3 and 4. Stage 1 is tumor that is within the muscularis propria. It hasn't gone beyond, so that is stage T1 or 2 with no lymph nodes and no metastasis. All right, so this is a very clear line to take the patient for surgery. Next is stage 2, which is disease which is T3 or T4 without any lymph nodes, without any metastasis. So this is tumor that has extended beyond the muscularis propria, but again, no lymphadenopathy and no metastasis. So the patient is categorized as stage 2. The moment lymph nodes start appearing, the patient is N3. So the patient moves on to stage 3. So irrespective of the T state, the moment there is lymphadenopathy and you move to either N1 or N2 without any metastasis, the patient is stage 3. And any T stage, any N stage, but the moment there is metastasis, the patient is stage 4. This is a very simple way of trying to categorize where patients fall. So very briefly, just in 2 slides we'll run through. Again, a patient has had an MR done. Just to summarize, if the disease is localized, which means it's T1, T2 disease, the patient heads straight for surgery. On the other end of the spectrum, if it is locally advanced, which is T3C or greater, and the patient has mesorectal fascia involvement, if there is any nodal involvement or there is extramural vascular invasion. In all scenarios, you will consider this as locally advanced tumor. Patient ends up with having neoadjuvant therapy, and then the patient goes for MRI restaging. One of three things can happen beyond here. I mean, the patient responds, so the patient ends up having surgery if they have partial response. They may not respond and continue to have chemoradiation. And nowadays there is a certain class where there is complete cytological response. And there is a certain school of thought which believes in non-operative management, which means that if the tumor has completely disappeared on cytological assessment on pathology, then you keep these patients on surveillance, which means just keep them on endoscopy, follow their CEA levels on blood, and get repeated MRIs done so that you can confirm that patient does not have disease. This is called non-operative management of rectal cancers. For people who are stuck in the middle, which means T3A and B, this can vary from institutional policies and varies on what guidelines one follows, but these can be treated directly with surgery, and they can be upstaged to having locally advanced disease and follow with neoadjuvant therapy. So to summarize, the patient that we were seeing, tumor is located in the mid-rectum, T3B stage, no mesorectal fascia involvement, no sphincter involvement, no extramural vascular invasion, and no lymphadenopathy. So this patient, according to this setup, is sent up for surgery because it is considered as a local disease and this can be treated first. So this is just a very, very brief summary, especially for the residents, to try and simplify how you guys can look at patients who have rectal cancers and how you can simplify in your assessment subsequently. Thank you.